Yeah, I know. Cavus foot, we broke it down real quick, but it is a lot simpler than everyone makes it out to be, because you see flat foot. Flat foot's just a more common thing that you're going to see in practice, whether you're in private practice or you're in a clinic. No, not a lot of people, unless you're in like a specific population that's seeing a lot of neuromuscular disorders, or people who are really like hankering for heavy surgery, because a lot of people have cavus feet, but they're not going to be down for a reconstruction the same way that someone with a pes plano valgus foot deformity is with like a PTTD. It's a little different. So you're not going to see as much, you're not going to do as much surgery on those patients unless you're in like a special population. Does anyone have any lingering thoughts from yesterday? All right. If not, then we will start up. I don't know, somebody has something?
Yeah, I have a question, Joe.
Yeah, what's up, Sam?
So for the 3PS, so it seems like you said don't be like a robot and just don't usually click on the same thing for every single patient.
Yeah.
But would you say there is like category where like for example like infection and like diabetic, those would be like a similar workup? Like would you categorize like certain cases by category? Like
so again, you can break it down mentally. Is it a whatchamacallit? If it's an infection workup, then you probably have some, like same thing as if a patient walked into the ER and you were called to go see them, right? You're going to order an ESR CRP, you're going to get labs, you're going to get, all these things to tell you if there's SIRS, if we meet our SIRS criteria and if we're septic, that's going to be a big part of it. So it's not dissimilar from that, but that's why I'm saying, ABFAS and CBPS, they want you to treat them like they're actually patients that you'd be seeing in real life. And you can do that, and that's how you should think it out in a thoughtful manner. But at the same time, it is a computer program. You do have the flexibility to shotgun in some places, but selectively.
Right, okay, thank you.
All right. So the other thing right now, we've got 52 participants. I know we've only got 50 people signed up, so somebody's got to go. I don't want to look through this list. There's 2 abattoirs, though. So,
Joe, real quick, back to that last question. I think this can clear it up a little bit. You don't want to shotgun your physical exam. That's where you can get yourself into trouble and not perform tests. But you can absolutely have general things you're going to pick based on the scenario. But the physical exam, you don't want to shotgun because you'll run out of things to choose if you waste stuff on doing derm, ortho, and vascular on every single patient.
Right. Yeah. Just to add on, like I remember you said like don't pick like same thing like repetitively like pedal pulse like DP PT, but would there be a case where like it's better to actually like let's say if it's like a severe vascular like compromise, like would it be a good idea to do all 4 of those like CFT, PT pulse, DP pulse, and
no, that's you're clicking the same choice 50 times, right? So get the information that you might need, which is like a capillary filling time might be useful to see if there's any fill to the specific area that you're looking at. And then pedal pulses, when I was taking the exam, I clicked that first. And a lot of the time you get your information that you need, or it says be more specific. And then you have to actually individually palpate a pedal pulse or the posterior tibial pulse, or you have to palpate a dorsalis pedis pulse. So that's how you would I would recommend doing it, just so that you're not wasting choices.
Would you say it's also redundant to like pick like Sam's Weinstein, like light touch, 2-point discrimination, like sub vibratory, like should we just pick one of them, or do you think like let's say for like neurofibromatosis that compromise like neurovascular structure, like should I do all like 4 of those, like all the neurovascular neurological exam, like 2-point vibratory and Sam's Weinstein?
So again, it's what's the purpose of a neurologic exam, right? It's to detect the presence of a loss of epicritic or protective sensation. You just want to make sure, do they have sensation or not? Are they neuropathic or not? If it's let's say you're chasing a tarsal tunnel workup, then yeah, you might want to do a Tennell's, which I'm pretty sure is on there.
Right. Okay.
Specifically. So, but cater it to the patient, right?
Yeah.
So if you toss in if you do a Semmes-Weinstein on the physical exam and it's normal, to me, it's like, if it's a neurologic workup, it's going to scream neurologic workup in the prompts, meaning that it's a diabetic, they're uncontrolled, and they're terrible. So they're probably neuropathic, and they probably have an ulcer. So then I would kind of use it in that scenario. But unless it's screaming neurologic, or maybe cavus foot is a situation where you do want to consider a neurologic workup, right? Because it can have implications, especially if it's unilateral. If there's some upper motor neuron dysfunction going on, and then if it's bilateral, considering Charcot-Marie tooth or something like that. So that goes back to your etiology of cavus foot, and then your neural workups in general.
Okay, thank you.
All right, Mazen, I would love to do that, but we gotta keep moving. That's what I had on that slide, though. Those are the most, that's everything that you potentially see that you guys will have available, and that's going to be the point of doing the separate CBPS reviews, to go over the most, otherwise we'll be doing that today instead of covering the material. Yeah, exactly. So it's not going to be an algorithm in the sense that it's going to be the same every single time, because each case is going to be a little bit different, right? Infections will vary kind of, but that should be the same almost every time. So that's going to be the idea of doing that in the course. So, okay. Does anyone have any last questions? We'll take any other question for the next couple minutes, and then we'll get right into it, and some PED stuff. All right. If no one else has anything going on, we will get started. And just like yesterday, if you have any questions about material that we're covering, drop it in the chat. I'll either look at it as we go, or I'll address it at the end of each section. But again, just like yesterday, please don't be shy. This is your guys' course. This is for you. Just make sure that you're getting everything that you can out of it. How will the course be organized? You mentioned something about Google Docs. Tom, specifically what? Are you talking about the slides, or? Tom?
I think you need the clinical.
Oh, the clinical? So yeah, I'll probably do it. So similar to how I sent you guys out the individual CBPS, and I'm going to make that basically on probably Google Slides, and I'll just share that so you guys have access. And I'll do the same thing for the slides for all the presentations, so you guys have access to view them. And that'll be set up with your Gmails. So that's why I was requesting those for both the slides today. And then if you sign up for the CBPS portion, then that will be through the same route. All right. All right. So if no one has anything else, let's get started. Get out of here. One more question. Okay. All right, so let's start on some PED stuff. You're definitely going to get some PEDS questions out of boards, whether it's a case, whether it's the didactic portion, so expect it. All right, so I had this in the manual, and I have this on here. You're not going to get asked a question about this per se, but if you look at the CBPS on the ABFAS website for their TEV case, this is something that they want you to look at. I don't know why, but this is something that's standard as far as if you have a kid, this is what they check just to make sure there's no dysfunction with the hips. So Ortolani's, just know that it's popping it in, and then Barlow's taking it out. Not much more to know. Don't worry about hip. And if at any point you learned about like skiffy or any of the other stuff, don't worry about that stuff. That's not going to come up. If it does, that would be completely ridiculous. This would be the only things that I would know about pediatric hip. And these are options as far as your CBPS goes. So it's something where if you're getting someone with a congenital deformity and they're an infant, I would probably do this. I don't know why they want you to do it, but they want you to do it apparently. So the only reason I can say that with like semi-certainty is because that's what's on the ABFAS site. So not something that I would have thought about had I not looked at the answer key. So all right, so brachymet. So I'm sure everyone's either seen or discussed at length brachymet. You're considering whether or not you're doing a single step lengthening versus a callus distraction. So you do too much too quick, then it can lead to soft tissue viability issues, meaning the token die, right? So if you tack on 2 centimeters of bone, one, you're probably not going to be able to just physically because the tissue has to stretch surrounding it. But the second issue is obviously you're stressing all the neurovascular surrounding structures, and then the toe will die, probably. So the main option that most people pursue is doing a callus distraction, especially if you need a large amount of correction. You're going to get a brachymet question in some form. There's no way it doesn't pop up. This is always a super, big topic because it's callus distraction. This isn't tibial callus distraction, even though the same principles basically apply, but expect it to come up on boards. You have to make it your osteotomy. Where do you make that? You make that in the proximal metaphysis. You're not making it in the diaphysis. You're not making it in the distal metaphysis. You make it proximal. And then that's going to be a transverse cut. It has to be transverse within the metatarsal bone. If you angulate it, it can either dorsiflex or plantar flex as you're distracting. And you want to avoid that, right? Not a good idea to have either severely plantar flex toe or severely dorsally dislocated toe. So you're making your cut perpendicular to the metatarsal, unlike for your correctional osteotomy for a proximal closing base wedge on your first met where it's angulated to the floor. All right, after you make your osteotomy, you compress it, give it around a week, and then you start cranking them out at 1 millimeter per day or 0.25 millimeters 4 times a day or 6 times, whatever it is. Everyone has their own like shtick when it comes to this stuff, how much they're going to do. But you do it until the length is reached. 1 millimeter a day is the board's answer though. And then consolidation is twice that. So what consolidation means is it's consolidating, right? So you need to be able to see osseous formation. You're not going to see that for a while. But once you do, then you can start transitioning them to weight bearing partially on it. But as far as the consolidation number, if you were given specific numbers on the exam, so the way that McLamber describes it is the latency period plus the distraction period, and it's twice that. Whereas, in the past, at school, we learned that it was just twice the distraction period. That's going to vary a little bit. I hope they don't give you both choices, meaning that the number is the same, or they're, basically if you had a latency plus distraction, and that was an answer choice at 2 times that amount versus distraction twice that amount, those both should not be answer choices. So you should have the option that is clear and distinct as long as you're doing math correctly. All right, so what are we concerned about with brachymet? Floating toe. If we over lengthened or we didn't put a pin in the toe, those are 2 ways that we can get a floating toe or a dorsally dislocated toe at the MTPJ. So you can avoid that by pinning the toe and then by obviously not over lengthening it. So as important as it is to know how to do this, it's also as equally important to know, just like anything else we discussed yesterday, what the complications are and how did we arrive at those complications. All right, metaductus. So as far as the vocab associated with metaductus, you have met primus adductus, which is just the first met. You can have a complex metatarsus adductus, which is also called the serpentine foot, where the rear foot is in the valgus and then the forefoot's in a metatarsus adductus state. A complex skew foot means that you're off at the midfoot. You could look at your calcaneocuboid joint angle, and that's off laterally to indicate, it's basically a combo flat foot with metaductus, right? and you have a valgus rear foot, and then the forefoot still in metaductus. It just makes it, a more complicated workup, more things to consider. You're treating it like a flat foot, but also with the added fact that you have metaductus. And, if you're lengthening that lateral column with an Evans, it's going to worsen the metaductus. So again, boards, easy decisions to make, right? All right, I'll do an Evans, I'll do a bunch of osteotomies to the metatarsals, and I'll do the flat foot. And if you want to be in the OR for 4 hours doing all that work, good for you. But that's a lot of work to do in real life. And brachiomed, what is the maximum you should lengthen? It's a percent, right? Is it 30% of the metatarsal? %. Okay, thanks, guys. Yeah, 40%. So yeah, it's a percent of the overall length of the metatarsal itself. So that is what you'd have to, and I don't think you're going to be asked. You might be asked the percent, but you probably won't be asked to actually calculate how much max length that you have to put on someone's metatarsal by, you don't get a ruler on the test, so it's not going to be something you have to necessarily measure. All right, how do we measure metatarsus adductus? You know how to measure your metatarsus adductus angle in general. Let's say you don't have bones to do the work because they're not ossified yet. You can use your Kite's angle, or you can use Engel's angle. If not enough bones are ossified to get that. And metaductus is nice because you're going based on age, and you want to use, again, this is defined by McLamory and other resources. Up front, you're doing a lot of casting, shoe therapy. In the middle, it's a bunch of soft tissue release. And once they're over 6 or 8, you can start considering met-based osteotomies. Again, with the caveat, if you're working at the first metatarsal base, that's where the growth plate is, avoid the growth plate. So birth to 9 months, and really birth to 2 years, right? Because if you're over 2 years, then that's when you start to transition to considering doing whether it's an abductor hallucis release, Heyman, Hearn, and Strong, which is really just the TMTJ soft tissue release. Again, don't worry about the eponyms as much as what you're actually physically doing to the patient, but it would be releasing all the TMTJs, pinning them, and then just letting it sit there. And then once you are 6 to 8 years old, again, the names don't matter as much as what the actual procedures are, but Lapeard is probably the one that is more commonly used. Closing wedges of the 1st and 5th mets, and then basically proximal wiles of the 2nd to 4th. Also, let's say you have gigantic deformities and it's less within the metatarsal region themselves, and you want to go a little bit more proximal. You can open the medial cuneiform similar to a codon, except for the medial side, and you can close the cuboid. So that would swing the foot over as well. So those are options that are on the table. Again, probably less commonly used, but important to know. All right, TEV. So outside of the fact that they literally have a TEV case on the CBPS site, expect a question on TEV. It would be, it should be hopefully easy to address. So how are we figuring out if a patient has TEV outside of looking at a clinical depiction or looking at an X-ray? Because the X-ray should be relatively obvious, but again, don't expect a 2020 X-ray on your exam. Expect something from 1995. So looking at your angles, your Kite's angle should be less than 15 degrees. The talus first met angle should be greater than 15 degrees. And the navicular is going to be displaced medially. You have a decreased calcaneal inclination angle, and the tails and the calcaneal are resting parallel. So what are the components of a TEV patient? You have cavus, right? So the first met's dropped. You have an adductus, which is, again, obvious from the clinical depiction, and varus and equinus. So again, that's the same order that you're basically addressing your deformity correction in general. So if you're casting, and again, so Ponseti casting is an answer choice in the treatment, and it could be something as simple as, again, I hope you did the case, but then you should know this in general, but for the case on the ABFA's website, it's a one answer insert where you're just Ponseti casting. That's it, because that's what you do at that point. But then they can ask follow-up questions where the patient comes back and they're 14 years old, and then you have to get creative and treat it like a residual clubfoot or just it becomes a cavus foot workup, but a little more complicated. So what do you do first? You're dorsiflexing the first ray, get rid of that cavus component. And then you're going to abduct the forefoot until you're at a steady 60 degrees. And then after that's done, you're going to do an Achilles tenotomy. Tenotomy, not lengthening, right? So tenotomy. And then you're going to keep them in a Dennis Brown bar with a valgus bend for, however long that's going to be. I don't remember. I think it's a couple of years. But and then what do we do if we mess up and we do something at the wrong time, and my 60 degrees of abduction is really 20 degrees of abduction, and I'm just bad at looking at the foot. If you dorsiflex the ankle too soon, meaning you start to address that, you can just bottom out the entire midfoot, and then you're dealing with a rocker bottom foot in a peds patient, and have fun explaining that to the parents. So let's say you do all your work, and they're coming back years later, and there's dynamic supination. You can resultantly do a tibialis anterior tendon transfer or a split stat. And the most common thing that's going to come back in the future that you might have to address is the cavovarus component, and that may require a posterior medial release. This image here, has like a less crazy looking incision than some of the other ones that are just that big, long incision across the posterior medial aspects and posterior aspect of the ankle. But you're lengthening all the soft tissue components medially, posteriorly. I think the only thing that you leave intact is basically the deltoid ligament, because, or at least I think the deep deltoid at minimum. But besides that, you're just lengthening everything and trying to get them in a more rectus position out of that cavovarus. All right. So you're not going to get a ton of questions from this. And this is like a crazy long section in McLamor's for no reason. I don't know why. It's just a bunch of case reports basically, or like what they do in certain situations. Polydactyly, to a greater degree would be something you potentially see, but it's amp the foot or amp the toe. So preaxial, you're going to see as a result of your surgery, if you're addressing a preaxial polydactyly, you can observe a resultant hallux varus. Central, you might observe splaying of the forefoot in general. And postaxial, which is the most common type. Again, your most commons are going to be the things that you want to just hang on to. Postaxial is the most common form of polydactyly. You might observe medial subluxation of the toe or a prominent toe. And macrodactyly and ectrodactyly, I mean, if they're asking you a question on that, good luck. I don't even know what they'd asked. But just know what they are. Macrodactyly is an enlargement, whether it's a toe or a portion of the foot, and ectrodactyly is that crazy looking cleft and lobster foot that's autosomal dominantly shared. Do you correct varus before Aquinas or Aquinas first? So I'm assuming we're talking. So as far as as far as the varus components concerned and like the order of it, I put that here just because that's the assumption that you're getting out of the Dennis Brown bar. You're getting that during the correction, during the casting as well. I probably shouldn't have put that there. It's just in the middle of it. So the CAVE is the acronym for the order that things are corrected. But the Dennis Brown bar is maintaining rear foot valgus as opposed to varus. That's the only reason I put it there. Ignore that. It's within the actual casting that you correct that as well, because you should be countering the calcaneus out of varus while you're casting them too, which isn't described verbally in or written down in McLamory, but that's how we're taught it, and that's how I remember doing it in school. So yeah, apologies for that. All right, and then syndactyly. So syndactyly is a situation where they can get creative on asking you different questions about what type of toe flap, something like that. So your options, right? It's make some sort of zigzag pattern, and then you're matching those up on each side, or you can just basically cut down the middle and then use a graft from the sinus tarsi full thickness to place there. And then of course you're going to see papers of people using split thickness grafts. Other things you can in real life, again, you can do whatever you want, but for boards, it's usually a sinus tarsi pinch graft, full thickness that you're going to insert into the cleft where you have separated the toes from. All right, congenital flat foot. So you have your two forms, right? Your calcaneovalgus, which is not really discussed a lot, I'd say. However, it is something to recall because it presents different than a convex pes plano valgus. And the point of doing a convex pes plano valgus stress plantar flexion is, or stress dorsiflexion, what did I say? Plantar flexion, yeah. So is that if it realigns, then it's technically more of a calcaneovalgus, meaning that it's a flexible deformity. If it doesn't, then it's convex plano valgus, and then not that the patient's screwed, but that's obviously a much more significant deformity. So calcaneovalgus is just your up and out foot type, flat foot, and you're treating this kind of like a TV backwards to an extent. The Kite's angle would be over 40 degrees. It's really just going to be conservative treatment, casting if it's severe or significant, and then orthotics long term. You're treating it like a flat foot once they start to ambulate. Convex pes plano valgus, as you all should know, and this again, convex pes plano valgus is something that you want to keep your eye on in boards. You should hopefully get an obvious X-ray like that one to the bottom there, where the talus is basically pointed towards the ground. But again, if it's a pediatric patient and you're getting an X-ray and you're like, oh my God, like I forgot what these X-rays look like I'm not sitting here calculating angles, like I can't do that. Just know your options, right? So, and look at the soft tissue. Again, we all get caught up in looking at the osseous structures on X-rays, but look at the soft tissue on your X-rays. If you're not getting a clinical picture like the one just above the X-ray, then just look at how the soft tissue appears on that X-ray. You see that there's a plantar rocker bottom bulge, right? You're not going to see that in TEV. That's not what it's going to look like. Lateral X-rays are going to be the more confusing ones to remember, but this should be obvious when you're looking at the X-ray. And then it's either going to be TEV, it's going to be calcaneovalgus, convex pes plano valgus, and then potentially like a metaductus. But you just have to have your pediatric diagnoses in your head so that when it comes to using them, you're not, flabbergasted or surprised that these are the choices that you're given. So when you're treating CPPV, the navicular is basically articulating with the dorsal neck of the talus. The Achilles is shortened. Again, it's a flat foot, equinus, right? And then Kite's angle is increased. The forefoot is abducted. The talus is vertical and the forefoot is dorsiflexed, right? That's why you have the rocker bottom. So like I said before, a stress plantar flexion view, and this is what you would do on CBPS. That's why it's there. You stress plantar flex it, and then you see whether or not the talus is realigning, and that'll tell you if it's truly CPPV or if it's just a run-of-the-mill pediatric type flat foot. All right, and then worst case scenario, what do you do with these patients? You can cast them, but understanding that this is a reducible deformity, the majority of them will require open reduction, internal fixation, or at least pinning of the talonavicular joint. There's many approaches. If you need a second surgery, it may end up needing a triple arthrodesis. Obviously, they would have to be at skeletal maturity for that, but it's rare that you're going to do, ORIF of the TNJ after ORIF and then keep going back for the same thing. If it's not working, then it might be time to fuse. This is a challenging foot type that you're not going to get, much resolve out of. All right, so pediatric fractures. So I'm sure everyone has memorized the Salter-Harris classification to death. And again, you may not get a particular question about Salter-Harris period, but you may be asked to identify, what type of fracture is present, what your recommended treatment plan would be, what the clinical outcomes are. So the weakest, and again, just like, buzzword type questions, the weakest area of the physis is the zone of cartilage maturation. That came up several places in practice questions. That's the only, as far as those zones, that's the only thing I know. That's the only thing that I went into boards knowing. I don't think it came up, but that's the only thing that I would recommend knowing. There's no need to memorize all the zones when it comes to actual osseous growth in a physis. So Salter-Harris, the classification, 1. So it might look widened, it might look, kind of askew off of each other. But most of these do well, right? So they probably didn't disturb the growth plate too much. You're just going to reduce them if needed and cast them. 2 is the most common, and so that's when you have your metaphyseal fracture, and you can either close reduce that. If it's significantly, gigantic, then yes, that might warrant an open reduction. But most of these can probably, be gotten away with just close reducing and casting. 3, this is an intra-articular fracture, right? So you want to address it at the epiphysis as needed. A lot of the time you'll see a 3 and it'll be like a a distal tibia fracture that they toss one screw across the basically, not in the articular surface, but just avoiding that, just maintaining the articular surface to ensure there's no step off. So then, as we head to 3, it starts to get to, the growth plate might be affected, and it's more important to reduce it than a 2 or a 1 because it's at the joint. And then 4 and 5, ORIF, again, it's sort of as needed, but then we can start to get some actual, serious damage to the growth plate, and then we might have to address the long term. So again, CBPS situation that you could be given, you get a patient with this, you do your ORIF or you do a casting or something like that. They come back in 15 years and now you have a malunited ankle and they ask you what you do supramalleolar osteotomy. So it could be as simple as that, and that could be a follow-up type question. So it's easy to, make secondary questions off of Salter-Harris injuries because the implications are usually angular deformity if they in fact do have a disturbance of the growth plate. All right, so for other, fracture types that again, could just be plainly asked for on a question where you just get an image. All it is just a torus buccal fracture. So that literally could be just a straightforward question where, it's a green stick where only one cortex is violated, the other one is not. Or it could be bowing, which would be a little, tougher, but green stick and torus would probably be the higher yield ones to just, take a look at an x-ray like I have pictured up there and understanding that, that's what's present. They would obviously have to give you something in the clinical history if it's a torus fracture, because that can be a little bit harder to read or pick up if they're not giving you the area where they're symptomatic. All right, and if you do have fractures about the physis, you want to opt for smooth K-wires if you have to traverse the physis, meaning go across it. Avoid doing that, obviously, if you can, but sometimes that's unavoidable, right? All right, so the ankle, as far as how the physis closes in osseous growth, it closes from anteromedial to posterolateral, to posteromedial to anterolateral last. So that's usually the last portion that stays open, and that is why you can have, your Talot fracture in juvenile patients, because that is still open. You can avulse a portion off the tibia at that point. Your triplane fracture, like Dr. Alabi said yesterday, is a type 3 on an AP. So that's pictured where? There it is, on the left one there. And then a type 2 is on your lateral. So these are complex fractures. You need to address them in both planes and ensure especially that the articular surface is addressed at the ankle joint. So technically these are type 4 injuries, right? Because we're across both. So even though we're in 2 different planes, we're still a 4 technically because we've crossed both the metaphysis into the physis and then into the metaphysis, or into the epiphysis rather. So just remember that this is one that that could easily come up. It's come up before. Just be able to recognize what a triplane fracture is, how it's commonly treated, and then again, just make sure that you have the views you need to make that determination. All right, so that was the pediatric section. Does anyone have any questions about peds?